We're a little late. The House ran long on the floor. And so I was just giving people a few minutes to trickle in. We're still expecting a couple more. So welcome to the Child Welfare and Foster Care Committee. The first item of business is, are there any requests for bill introductions? And I have one that's RS number 0507, and this will be Representative Gail Finney Memorial Foster Care Bill of Rights. Are there other requests from the committee? Okay. Any from the audience? Okay. We'll move right into our bill hearing then, and we'll start out House Bill 2034. Open the hearing with an overview from the reviser, Jesse.
Hi, good afternoon, committee. Today's hearing is on House Bill 2034. I'm going to first go over the contents that you find in House Bill 2034, and then I'm going to review some of the previous versions of the content that the legislature has seen and highlight some differences for those who have heard about this bill before. So House Bill 2034 proposes a program and a process to medically examine a child who is alleged to be a victim of abuse or neglect. So first off, there's some definitions that the bill proposes, such as a care referral. And this is, if you're looking in the bill right now, this is not the first section. Some of the sections, they're a little jumbled up due to how sections in the bill go numerical. So I'm just going to go over the definitions. So a care referral is a brief written review of allegations of physical abuse, emotional abuse, medical neglect, or physical neglect that are submitted by the secretary or a law enforcement agency for a recommendation that for the child's needs, medical needs, to be reviewed, and those needs may include a care exam. So a care exam means a forensics medical evaluation of a child who's alleged to be a victim of abuse or neglect, and those exams are conducted by a care provider. And a care provider is defined as a person who is licensed to practice medicine or surgery, an advanced practice registered nurse, or a licensed physician assistant who performs care exams and provides medical diagnosis and treatment to such children. And then there are some more specific requirements about continuous trainings, peer review, and mentoring of these providers. So next, what really kicks off this process for these medical exams is that House Bill 2034, and this is going to be the last section on the last page. You'll find it amends KSA 382226. Right now, in current law, it's a statute that requires a visual observation of the child during an investigation of child abuse or neglect. What this bill does, it adds a new section that would require, upon assignment of the case by the secretary of an investigation of physical abuse or physical neglect of a child who is 5 years or younger, the secretary of the law enforcement agency shall make this care referral. And if we think back to the definition, that referral is that brief recommendation for those child's medical needs. And then the provision after that is that the secretary or law enforcement agency may make a care referral for a child more than 5 years of age when there is an investigation of physical abuse, emotional abuse, medical neglect, or physical neglect. So once that referral has been made, in Section 1 of the bill, if you're looking at the bill, when that care referral is made, it is made to a medical resource center, and that center either recommends a care exam be conducted or not. And if during that exam, a care provider determines that a child has been subjected to physical abuse, emotional abuse, medical neglect, or physical neglect, then that will be in a completed review. That completed review is then given to the secretary and the local law enforcement agency, and that review is then included in that child's case record under the secretary's purview. That review, all the reviews are confidential. So this new section also outlines opportunities for collaboration for the provision of forensics evaluation services to these children who are the subject of care referrals or care exams. And it goes into detail about resource centers collaborating with each other, providing trainings with each other, and other items like that. So the agency that oversees a majority of the implementation of this program is the Department of Health and Environment. So the Secretary of Health and Environment shall implement and administer training for the program. And also, the Secretary of Health and Environment pays the charges for these exams. So they only pay for the reasonable cost of the exam. And the process to be paid is a provider shall submit all the charges for the payment to the secretary within 90 days of that review or that exam. And then within 30 days of submitting that charge, the secretary is directed to reimburse the provider for that review or exam. Additionally, in order to do so, there will be a child abuse review and evaluation fund administered by the secretary. This would also be used for training of providers and provision of forensics evaluation services. Additionally, the secretary will manage a database for all these referrals. And this will be all a part of the Child in Need of Care Code. So those are contents highlighted in 2034. In anticipation of some questions that may arise today, I'm going to highlight some differences between this bill and 2632, which was seen and proposed last year. In section 1, there's no longer the authority of the Department of Health and Environment to do rules and regulations further than what is currently in statute. Secondly, in the definition section, Child Abuse Review and Evaluation Network was amended on the floor to include child advocacy centers. You will find that that is in this new bill. And making sure I get all of them. The new bill includes this referral system database, so that has been included. The very specific timeline of the 90 days and the 30 days, that has been specified in this new bill. And those are all of the large changes that are different from previous bills, and I'm happy to answer more questions about any of those changes. Additionally, last year in the omnibus bill, the legislature provided $757,000 through the Department of Health and Environment, the Division of Public Health, to a child abuse review and evaluation program. And that proviso states that the expenditure shall be made from the Child Abuse Review and Evaluation Program account to train healthcare providers to recognize signs of child abuse, and reimburse reviews and examinations conducted by such trained healthcare providers. And then additionally, that proviso requires the Kansas Department of Health and Environment to report to Senate Ways and Means and House Appropriations on the use of those dollars by January 9th. So the bill was introduced, the bill passed this committee, was amended on the House floor, died in the Senate. This proviso popped up, and then this year, this bill is before you. So that's kind of some of the procedural background, and I'm available for questions on House Bill 2034.
Okay, committee, do we have questions? Yes, Representative Howell.
Thank you, Chair. Being the newbie on this committee, can you or anyone explain to me why are we involving the Secretary of KDHE instead of the Secretary of DCF in this bill?
Jesse, can you respond to that?
I would refer to the requesters.
Okay, so when we have the conferees, yeah, that it might become more clear what the process is. Representative Humphreys.
I'm also not sure if Jesse, you're the right one, but the fiscal note, but probably are. So the fiscal note is about 750,000. And but also you said that you could, that there's some provision to raise funds. And do you know, I mean, what does it say in the statute that is going to know that we can raise funds, or, do we anticipate? I think that 750 is in the governor's budget this year for this term. It says that here. So I just was wondering how would there be funds raised, or, I thought that's what you were saying when you were explaining. Yeah, it's a little bit of explanation on that.
Jesse?
Yeah, definitely. Representative Humphreys, so the bill talks to the creation of the fund just as a fund in the department that will have these monies in order to implement this program. But it's not funds as in raising fund or charitable efforts, or there's no statutory language here proposed that would give the department or the program the explicit authority to raise money.
Yep, okay. And if I may, the database is confidential, that we would.
I would assume that the database would be importantly subject to HIPAA since it's related to medical needs. So that would be an application, but the bill does not say, and the database shall be confidential. But it's likely HIPAA applies in the situation. And I'm not sure if the conferees have already instituted this database, and they may know a little more about what it may be subject to.
And then just quick, but this may be the conferees. So we had a trial, or didn't we in the pilot program. So will we get a report on the pilot program from the conferees?
Yeah, I'm seeing nods, but.
Okay.
So the pilot, the proviso stated by January 9th. So there should have been a report to the legislature by now if we can, but maybe we'll hear about that from the conferees.
Okay, thank you. Thank you, Madam Chair. Thank you, Jeff.
Okay, any other questions? Thanks, Jesse. Okay, so we'll open up the proponents, and we'll hear from Dr. Jennifer Hansen and Dr. Emily Killow that were here last year, so we've become a little bit familiar with them, and welcome to committee. Are you guys going to tag team?
We are, if that's okay with you.
It is.
Okay. Well, Chair Kincannon and members of the committee, thank you so much for having us here today. I'm Emily Killow. I'm here representing the Kansas chapter of the American Academy of Pediatrics. And we share with you the goal that all children and adolescents in Kansas grow up safe and healthy. And it's with that goal in mind that we would like to share our support for House Bill 2034 that creates the Care Provider Network and answer any questions that you have. Since July of last year, KDHE, DCF, and the Kansas chapter of the AAP have been collaborating on the coordination of the CARE program. And so we are here to report our progress, and we are very grateful for your interest in assuring that these cases of potential child maltreatment are thoroughly investigated, and we want to take this moment to thank you and the legislature for enacting the proviso, which has helped create this foundation for our network. And while the proviso is a great first step to establish this network, we do think that having a permanent law will be really key in helping the network reach its full potential and ultimately save lives. And passing House Bill 2034 is necessary to sustain this program. So we wanted to provide you with kind of some updates of things that have been happening since July. And first, just since we know there are some new people on the committee, just sort of give a high-level explanation of how we envision this process working. So the first step is basically when a report comes into DCF with concern for physical abuse, physical neglect, emotional abuse, and I'm forgetting something, medical neglect, then the DCF specialist sends a referral through this statewide referral system, which we've created with KDHE, well, really KDHE has created, with input from both DCF and then KAAP and the medical resource centers. And so it's called IRIS, and it is a confidential and secure database that's used. And I think it's going to be really helpful, not only as a referral system and a referral process, but also will enable us to give you back data in real time and to really show everything that is happening as a result of those referrals. So the DCF specialist will then send that referral with information regarding the allegation, the concern, a brief summary of any additional information, and if there are injuries present on that child, or if there are allegedly injuries present on that child. And then the medical resource centers in either Kansas City or Wichita, which have child abuse pediatricians who are board certified, then provide that recommendation as to whether that child would benefit from a medical exam. And then that recommendation is sent back to the DCF specialist, who then can refer that family and that child for that medical exam. And the thought is that we want this network of providers across the state of Kansas so that children can be seen in their own communities, so that they're not having to travel far distances for a medical evaluation. And so that's been sort of our next steps, which Dr. Hansen will update you as to sort of the progress with creating the care network and then the reimbursement system.
Thank you, committee. So we had our first care provider training in the fall at the end of September of last year. We had 24 providers from across the state, including nurse practitioners, physicians, physician assistants. They encompassed in hospital systems, emergency room, urgent cares, primary care providers from family medicine and pediatrics, primarily pediatrics at this point. From across the state, in your written testimony from us, there's a map, and I don't know, yours looks like it's black and white, but the hearts at Kansas City and Wichita are us, the board-certified child abuse pediatricians, and that was sort of the pre-existing state. To get a medical provider who had any training in the evaluation of abuse or neglect, a child from anywhere else in Kansas had to come to one of those two places. So all of the other hearts now represent places where there is now a trained medical provider who can see those kids in their local communities. So we have pretty good geographic representation. It's really great. Additionally, we have many providers who have already expressed interest and reached out for being in the next round of training, which will happen sometime in September of this year. So that part is going really well. So that initial training is a 2-day training. So these providers come and they get really intensive sort of education from the board certified child abuse pediatricians in both of our medical resource center locations, so that they know how to do an evaluation. They know what testing to do. They know what not to do. They know when to be concerned, when not to be concerned. And they also know how to communicate and sort of function within the child welfare system in a better way so that they can share that information with the right people. Each of those care providers is directly linked with a child abuse pediatrician who is their mentor. So every time they see a case in their local communities, they review that case with their child abuse pediatrician mentor. So again, they get that one-on-one case level review to provide expert input that they really didn't have access to before. So we have those providers trained. We have also been meeting like Emily said, with KDHE and DCF leadership and KAP every few weeks to roll out this process, to develop the sort of infrastructure for the referral system. How do we get the referrals to us from DCF, and then how do we get them back out to our communities, to our care providers, so that they have the same information and can do the same sort of medical evaluation that we would do if they came to us. So IRIS is an online referral system Emily mentioned. It was pre-existing. It's sort of run by KU. Getting my back up here. It's sort of run by them, and it's a community referral network that people are using across the state already, so for other sort of community service networks to link families to them. So we've sort of adapted it and built in some changes so that it meets our specific needs. The medical resource centers, I mean, it's KU Pediatrics and Children's Mercy. Our hospitals have reviewed all of this and agreed that it's HIPAA compliant and meets all of the patient privacy needs that we need it to, so that we can share that information. Currently, that system is almost ready to go. Now that we've worked out all of the kinks, there are a few sort of outlying things that still need to be addressed before we can truly roll it out. In the meantime, you asked about the pilot, and so that pilot program, we've already been doing the care referral, so that written referral to us in the Kansas City, the DCF Kansas City region, which is Johnson, Wyandotte, Atchison, Leavenworth, and Douglas, so 5 counties up there. And right now it's being done by secure email, basically, so they email it to us and we email it back. It's great because we get that sharing of information and we're getting the medical information to them for their investigative purposes. It's challenging though because there's no way for us to track that in any real way. It's a Word or a PDF document that gets sent to us, so there's no database that we can pull data from. So it's right, it's manual. I have to review them by hand to get stats and things like that. So it's not really sustainable to continue doing it that way. So we're excited about the online referral system. And also in your written testimony, there's some comments from one of our child abuse pediatricians down in Wichita, just sort of saying this is working. And we've had similar experiences, but basically what she's saying is that she had a set of siblings that were on her schedule for a child abuse evaluation. They were moved placement, so they got placed somewhere else that was a distance away from Wichita, and their foster family, it was going to be difficult for them to get them there. And so we were able to be like, hey, you know what? You're out here, and we've got a care provider there, so we can get you out there and get you the same sort of care and make this as easy as possible. We've had similar experiences. Just last week, I was talking to my mentor here in Topeka at Stormont Vale about a kid that we had initially been called about, and they were going to try to figure out how to get them to us, and we said, wait, you don't have to do that. We have someone there that can do this now. So in terms of moving forward, we have certainly made tons of progress getting this infrastructure done and moving forward with the project and getting training for our DCF partners and for everyone else to sort of get us all in the same place where we can do this and get it rolled out. So the proviso and the budgetary support certainly has made that possible. It is, I think, going to be important for the bill to pass to give us statutory support for this, though. There are some challenges. One of them I already said, like this email system is not sustainable. We can't do this forever, and I can't give you information from it. So we need this online referral system to be used. But also statutory support would let us codify these best practices, right? Child abuse evaluation is multidisciplinary. It's not just DCF, it's DCF and law enforcement and medical. And we all have our own different policies and procedures. So I can change something in my hospital, but it doesn't change other medical practices. It doesn't change DCF practices. It doesn't change law enforcement practices. It doesn't inform this. And so because it is a multidisciplinary system, codifying this and giving statutory support for this will allow for these things to continue long-term, for us to build on the progress we've made, to measure outcomes, to continue to sort of develop training and implementation procedures that will be important for us long-term. Thank you, and we would take any questions.
Okay, thanks. So I've got several questions that some of them I think I know the answer to, but it's things that we've talked about in the past that, but thank you for being here. Every time we call and ask for you guys to come and talk, you've been willing, and I really appreciate you taking the time away from your practices. And thank you. I attended the training in Salina for one afternoon, and I was really, really impressed. And mostly, I was really surprised with the geographic area that was covered by the. How did that happen? I mean, you just put out the offer for the training and.
It's our KAP director, but yeah, she put the word out. And also, I will point out that we got this distribution and this number of people on about 6 weeks' notice. Yeah. So this is not even people that knew that this was coming 6 months from now and I can block my clinic schedule and things like that. And so we anticipate having more participation when we're able to give them better notice.
And many of the attendees said, we're doing a lot of this work and we want this education. We want this support. We're seeing these kids in our practices and we want more support and more training to do this work.
Well, I know I mentioned it that day that I know of 2 physicians in my district that were interested. They just couldn't make it happen on short notice. So can you address the question on why KDHE? Is that something that we need to direct towards the agency?
So KDHE, I can speak, I don't know if anyone's here, but I can speak to it.
Ashley's here, I know.
Sorry, I'm looking right over you. But they are the payer source. And so billing for like Medicaid reimbursement and things like that already go to KDHE. And so it was the, how do you reimburse and that sort of thing. Certainly the Secretary of DCF is also involved in this process. And so I don't know if there's maybe some confusion in the bill about secretaries.
Other states that have set up similar systems as well, there's been a thought that it's actually helpful from a payment and reimbursement system to have these things separated so that there is not any type of like.
Improves transparency.
Yeah, that it's transparent, that it's not all going through DCF, that you have multiple systems involved, that there's no thought that there's any type of bias. We want it to be very clear that we don't reimburse only when a child is diagnosed with physical abuse, for example, that it's about the evaluation, that a provider doesn't have to make a diagnosis of abuse or neglect. They can say, hey, this is a medical condition, or this is an accidental injury, and they're still reimbursed for their time of doing that full evaluation, and that the payment is not linked to an outcome of an investigation or a diagnosis of abuse, because we want this to be transparent and unbiased. And I think that was part of the thought process of using both agencies.
And it's consistent with how we handle Medicaid in the state with aging and disability as under KDADS, but eligibility and payment is under KDHE, and it just makes Medicaid even more confusing. But once you know who the right person is to call, it is convenient to have it all under one roof. So could you explain how these exams are different than a regular exam of a child?
Sure. So when people come to our clinic for one of these exams, they frequently say, I have never had such a thorough exam in my life. The parent's telling us this, not the kid. So it's a really detailed physical exam. We're presented with a child with an injury. So our evaluation is going to include an injury history. Like, what do we know about how this injury occurred? Sometimes it's nothing. We have no information. Sometimes there is a suggested mechanism, and we have to evaluate whether that mechanism that they're telling us makes sense, it matches the injury or not. So there's a history of the injury. There's a detailed medical history, a family medical history, developmental history, a head-to-toe physical exam. We are looking at literally every piece of their body from head to toe. It frequently involves laboratory or radiology evaluation. In little kids, they frequently need x-rays or head imaging or belly imaging. Then it's sort of, we wrap all of this together, tie it together, and hopefully are able to give you a diagnosis. Is this injury abuse? Is it not abuse? Is it actually not abuse and not even an injury? It's a medical problem. And so there's a lot of diagnostic consideration that goes into it. Then whenever kids come for these evaluations, typically they have DCF involved, law enforcement may be involved, and so then after the exam is done and after the family leaves our clinic, we then have to share our information with our multidisciplinary partners. I don't want DCF trying to or having to enact safety plans or make recommendations for a family if really this child has hemophilia. And so we have to communicate our findings to them, to law enforcement, and get information back. So sometimes what we actually need is information that DCF or law enforcement can give us. So sometimes parents might offer us a history to explain an injury, but I need pictures of what they're talking about, or I need, measure, if, maybe I need to know how high, like, can the child actually do the thing that they're saying? So I need someone who can go to the house and get that information and share it back with me. So it's a two-way street of information sharing. If there is a diagnosis of abuse, then frequently our involvement is not over. We get subpoenaed to go to court, to sync, to family court, to criminal court. And so that 2-hour clinic evaluation, by the time that it's done, may actually include 20 hours of work once we've added up all of the pieces that a medical provider has spent on a case. Does that answer your question?
It does. But but it leads right into the next question is, why do we need a special payment method for this? Does insurance not cover it?
So insurance and Medicaid cover it, but they reimburse it as a basic physical exam or a basic like general complaint. So it's reimbursed very poorly, and it does not cover the time that a provider needs to spend on this. Our providers are also tasked with that initial 2-day training. They are also required to have 6 hours of continuing education training specific for child abuse every year. And so again, we have time commitments that we're asking from these providers above and beyond the medical care and their follow-up on each case that they're being asked to do. And so the reimbursement rate was developed, again, consistent with what other states are doing for their medical evaluations, but it's to account for all of the extra time that is needed for these cases. I would also put that when they go to court or when they're asked to serve as an expert in court, they're not charging additional money for those. Medical experts, when they are asked to come testify in court, typically charge in the range of $400 to $600 an hour. And so none of that additional charging will come. It's sort of built into this single lump sum reimbursement cost.
And so when we've talked about this in the past, when you get a report and you look at that and you make it seemed like there were like 4 options of what you would, can you go over what those are?
So when we get the referral from the DCF specialist, we have options, like you said, of what we can select. And one of them is no medical exam is needed at this time. And sometimes that's because maybe they have already had a medical exam, or the concern that was reported, sometimes it's even things like it's already been previously investigated or was found. Some of the neglect cases, there's no medical concern at that point, or there's no injury concern at that point. And so those cases, we would say a medical exam's not needed. So there's many cases where we don't feel a medical exam is needed. There's some cases, a good example would be a child with failure to thrive or not gaining weight well, where it would be appropriate for that child to see their primary care doctor. So we want their primary care doctor, so that's another one of the options we can pick. You should see your primary care doctor. Or if there's concern that the child's been in a house where there's been exposure to substance abuse or something like that, so a more neglect concern, we would say that child should go to their general practitioner for, an evaluation to make sure that they're healthy and their vaccines are all up to date and things like that. And then there's another option that says, like, this kid needs to go to the ER now, so it needs like an urgent evaluation. So that could be something, that doesn't happen very often, honestly, that we pick that, but it's on there as an option. And then another one is this child needs to see a care provider. So those are sort of the 4 options. Did I miss any of them?
Nope.
Okay.
And so I know that we had some discussion before about this being a tool that would actually prove that there was not neglect or not abuse. Does that? I'm sorry?
Speak to that.
Yeah.
Yeah. So I think there have been times where we could prove that something was an abuse. So there have been examples where a report comes in for concerns of physical abuse, and then we see the child and we say, actually, this is XYZ medical diagnosis. So we can say that this skin finding is not due to abuse. This is from another medical problem or another medical diagnosis. I think that's the most straightforward one. Or we'll say things like, yes, that accidental explanation absolutely fits with the injuries that we're seeing, and we don't think that these injuries are from abuse. There's other times where it may be unclear, or there may be 2 possible explanations, and we will look at the injury, look at all of the histories, and say, this history fits, this history, wouldn't explain the findings that we're seeing medically.
Okay, I think that's all my questions right now. Members of the committee, Representative Howerton.
Thank you, Madam Chair. So just to clarify, is this already in the budget currently to pay for all of this?
Yeah, if you will pull out your
Help me with that.
the fiscal note, I just saw that. It states
Okay.
that it is currently in So the third paragraph, second line, state general fund is fully funded in the governor's recommended budget.
Okay, and we had 28 providers, and then how many cases do you do annually?
We don't know yet. So we just trained the providers at the end of September, and then there was a little bit of delay once they were trained for us to develop the billing system for KDHE.
Estimating.
So I think our estimation was 700? Around 750 exams. In our experience, we have a similar program in Missouri, and other states have a similar program. That's based on DCS statistics for the number of children who may be eligible. That likely is an overestimation. It's just based on like the number of referrals DCF gets. But part of the problem is we don't know yet.
You mentioned Missouri. How many years have you been operating this system in Missouri?
10, I think it started at the end of 2012.
About 10 years. Representative Pickert.
Hello, thanks for being here. I'm a retired nurse, and my last job was with Children's Mercy in Wichita, so I'm very familiar with KU Peds and Children's Mercy, and I know Dr. Melhorn. So some questions I have, though, one of them is, what's the estimated time, or what would be the ideal time from the time it's identified that a child needs an exam till it's actually done? I mean, what would be realistic? And
So realistically, I mean, if I could have a perfect world, as soon as you recognized a child needed an exam, they were able to get to us, right? The way that the program is set up is that we would like that written referral within 3 days of an assigned investigation, so that ideally we do have that information up front and we can make the recommendation for a medical evaluation up front.
And the ask when we trained the care providers was that they had a way to get these kids into clinic in a like 24, 48-hour kind of fashion, that we understand there may be some day-to-day variability with weekends and Fridays and that type of thing, but that this isn't like come in 3 weeks. This is come within the next couple of days. So seeing kids in a more urgent fashion, and that was one of the things that care providers were thinking through and talking about at the training, and really thinking of ways that they can, you know, use their schedule to be able to see, kind of save a spot or that type of thing to problem solve around that.
okay. And then, yeah, and I know a clinic is very hard to get into sometimes, so that's good. Another question I have is, so it's about a 2-hour exam, so more or less, depending on the age of the child and all of that. Yeah, okay. How much does that cost? I mean, how much is the charge for that? For the whole gamut. I know that it may involve going to court and all that, but you know, there's one charge, right?
Yeah, the reimbursement rate that I think that we have asked for is $750 per case.
Okay, any follow-up?
No, that's
Okay.
all for now.
Yeah, just a sec. I had a question myself. And Representative Howerton. That's all right.
I was just going to follow up on that. The $750 is based on what? Like how many hours or, yeah.
Again, we had to sort of come up with a number. It's what is used in Missouri, and again, it's comparable to what's used in other states. When we came up with it for Missouri, it was based on sort of an average number of hours that we spend per case, spent at sort of our hourly rate at the hospital, which was, I don't know, around $100, and we were estimating on average 8 hours a case. Once you include the exam and communication in court, some cases will be less, and some cases, like I said, will be 20 hours. And so it was based on a rough estimate of about 8 hours and reimbursement of around $100 an hour.
Just talking through that process, you know, when I was tasked with explaining this to my colleagues, I kind of got lost in the process of when you make that referral, who are you making that referral to? Like, are you calling the doctor's office that's a care network? And then is the doctor's office calling and at the family and asking the parents to, and who brings the child in?
That's a great question, and the answer is it depends. So typically what happens is that we provide the recommendation of, I'll use the example of this child needs an exam by a care provider. We provide that to the DCF specialist. And then we basically give the DCF specialist, we think this child needs to be seen within the next, ideally 24 to 48 hours. Here, right now it's in our region, right? So we say, here's our intake line. And what DCF, at least in the Kansas City region, has done, has asked the parents to call that intake line, or the caregivers, whoever the child is with, to call that intake line to then schedule the appointment with our appointment people. And so the parents call, it's usually our social worker that takes the call, walks the parent through the appointment process, what's going to happen, and then comes up with an appointment date and time that works for their schedule as well. So sometimes that window gets pushed a little one way or the other based on that family's availability. And then it's typically one of the child's parents, caregivers, or family members, again, depending on that specific child's living environment, caregiving environment, and any safety plans that DCF has developed.
I will just add to that, the case that I did last week in coordinated care here in Topeka, I said, this kid needs an exam. I gave that recommendation back to DCF. And I said, and they could come here. I would see them if that's what you want. But here are 3 local care providers in the Topeka area. Your family can pick one of these. Your kid's already been seen in the Stormont Vale system, so why don't you go to this one in Stormont Vale? And that's what they ended up doing.
And what if the parents don't cooperate?
So that is really DCF's
Okay.
decision and their prerogative as to decide what the next steps are if the family refuses. So we can't make anyone come see us, and it's really up to DCF. And sometimes the family wants to see a non-care provider, and again, that's the family and DCF's decision in terms of kind of that next step.
Okay. Representative Humphreys.
Thank you, Madam Chair. So sort of on the same line, there's just a couple things I'm still a little bit confused about. So you're amending Adrian's Law, which we had said, what Adrian's Law was there's a call made to DCF that there might be child abuse, and so they have to see the child. It's eyes on the child. And so what I don't understand is, and so I'll say what I think you're saying, but you tell me if this isn't right. There's a call, teacher, mandated reporter, whatever. Someone from DCF or law enforcement goes to the house. They say, oh, okay, I think this might be substantiated. I make a care referral. And then, so that's step one that I don't understand. Who makes the care referral? Yeah.
So it's DCF makes the care referral, but it is regardless of whether if it's assigned for investigation. So it's regardless of what their impression is when they go see the child. It's if it was assigned for investigation, all kids 5 and under, it's sent for a referral.
But there's some sort of process that DCF goes, they get all of these calls, and somehow they've gone through them and weeded out the ones that they don't think that they don't need to go out and see. Is that right? So it's not every single call they gets a care referral.
Correct.
Okay, so someone calls, they hear, okay, this does seem like something we need to investigate. They go out, they see that they still have to have eyes on the child, or they do not? No, they do. They still have to have eyes on the child. Okay, they have eyes on the child, but you said regardless if they do or don't, they still have to make a care referral, so that's confusing.
Sure. So, and that may have been my interpretation of what you were saying. You said that they look at the child and they decide that, yes, this is concerning, then they make the referral. So when they look at the child, even if they think that the child looks perfectly fine, they don't see any injuries, they still send a care referral to us.
Okay. Okay.
Yeah.
Can I add one?
Yeah. Oh, please.
Okay, so I think the important thing, and I'm gonna use Adrian and other kids like Adrian as an example, is that DCF has very specific expertise, training, education, and are experts in their field. but their expertise does not include a medical evaluation, right? And so in my experience, and I'm going to look at Tanya to help me out here, but truly, it's really that I don't want the DCF investigator to feel like they have to decide in that moment, is this bruise concerning for abuse or not? I want them to say, hey, this child has bruising, and hey, there's this allegation, and now I'm going to send this referral and get medical input. Does that make sense?
Yeah, that's helpful.
And so I think the issue that we've seen, in not specifically in Adrian's case, because not everyone laid eyes on him, but I can think of numerous other kids who someone laid eyes on them, and someone believed the explanation that was given to them by a caregiver for the bruising, and then that child never had a medical evaluation. And I have downstream seen the pictures and said, absolutely not. That explanation does not explain those injuries. And what if I had seen the kid at that point and been able to provide you with that information, maybe this kid wouldn't be dead. And that's really what we're getting at.
Mm-hmm. And so the care referral, is that like a form? I mean, could we see what it looks like? Could you send that to us?
Absolutely.
What the care referral form looks like? So, okay, DCF sends it, or law enforcement, right? Either one or the other sends it to you. And I mean, when I say sends it to you, are you the care?
Literally us.
It's literally
The two of you, okay. And what's your
Yes.
organization called, or what are you, I mean,
Well,
So in the bill, we are the Care Resource Center.
okay, thank you, that's great. Okay, the Care Resource Center. Okay, so the two of you look at every care referral?
currently, yes, because it's only in the northeast region of the state where we're getting referrals from right now. When it goes statewide, we'll partner with our child abuse pediatricians at the Resource Center in Wichita, and one of us will review all of those referrals.
On sort of a rotating basis.
Right.
It won't be Emily's job for the rest of her life.
It might be, but
Is it taking, how much of your time does it take up now?
it honestly depends. Sometimes I get a referral and I'm on the phone with DCF and problem solving and thinking through things for hours and hours, and other times it's 30 seconds.
And you might get a referral how often?
Oh, every day, multiple
Every day.
referrals. Yeah,
But you have other jobs too?
yeah.
Okay, all right, so, okay, so that's super helpful. You say, you look at the short, brief referral, okay, they need a medical exam or they don't, one of those four things that you said. And then you tell DCF that, and then DCF talks to the parents and says you need to set something up. That's the correct way things go. Okay, and then the parent calls to set up something. Are the parents allowed, or when it's under 5, which is what this is about, the parents are allowed in the examination room?
Again, that is kind of also up to DCF, but typically, yes. Sometimes the kid lives with their grandparent or lives with an aunt, or the parent is,
They have a caregiver or guardian in the room with them?
yes, unless the child doesn't want them there. So I want to be like very transparent that if a teenager says, I do not want this, I do not want anyone in the room during my exam, which sometimes happens, we let the kids choose that too.
Okay.
But we would still talk to the caregiver just separately, but
So how are you all getting paid for all of this? I mean, I know you said, that it's maybe $750 per case, but is that to the physicians who are doing the exams, or you all get some of it too? I'm just, really trying to figure it all out.
I have a salary through Children's Mercy, so I only get paid my salary.
And they have agreed that this is part of your job description?
Correct.
Yeah, great, okay.
I don't make any money from any of this. I only still get just my salary that I make at Children's.
But your job description does include this in it?
Currently, we have
No.
a grant contract where
that pilot
Children's Mercy, because that's my employer, would get paid a small amount of money for my time, so that it allows me to do this instead of, seeing patients during that time, if that makes sense.
Thank you for doing that. Okay, I'm sorry, I'm almost done, if that's okay, thank you. And so, one thing is I really look forward to seeing the report of the pilot program. I mean, the numbers and, what of those 4 categories, what you decided and who went where and all of that. So, and also I hope it has ages on there, because I know under 5 is a must. and then over 5 as you may. So I'd love to see the numbers for those. And just to, I know this was a little confusing to me last year, that this doesn't include sexual abuse.
Correct.
And this is just the ones that you mentioned, right?
Yes, this
Okay.
already has a reimbursement process for sexual abuse forensic exams and at a county level, so that's why those are not,
Yeah.
that was not included.
Okay, because that was a little confusing to me last year. Okay, I think I'm almost done. The 757,000 that's in fiscal year 2023, can you break out how much is for the training in September that you have upcoming? Well, I do, and how much is for the reimbursement of the examinations?
I'm going to defer to my partners.
You can get that to us later.
Okay, yeah, we can get
Okay,
that.
but then the one other question I had was, if it's a pilot program in Northeast, but you said you referred people to Topeka, how did that work?
We're kind of in this gray area right now where statewide, we are in the process of rolling it out. Our pilot is only in the Northeast, the Kansas City region. It was this complicated thing where it was like 2 children from different areas that lived in the same care environment. So we got it from the KC region, but it was like a sibling that lives in Topeka. It was,
I didn't hear you say Shawnee County.
was
so I just-
confusing.
yeah, Okay, okay, I think that's it. Thank you for letting me ask all those questions. I appreciate that. Thank you.
Well, we want it to be real thorough. I just want to follow up on, so you already, before we had this bill last year, you already had the pilot in the Kansas City area. And then we put the proviso on the budget that allowed for. I guess I thought that that was going to already start the process out into the rest of the state. Was it just the process of educating that?
the process of educating and sort of like building the online referral system, you're right. The proviso includes this to be statewide. It hasn't rolled out statewide yet because we needed more infrastructure for that because, again, Emily and I can't just man an inbox for this to be emailed to us. We had to have more infrastructure for that to work. So we, last year, we were doing Johnson and Wyandotte counties only. So we expanded it to the 5-county region to get sort of a bigger sort of pilot, basically, to get more feedback and input to see if there was anything about that referral process we needed to change. And again, that sort of infrastructure for the statewide network is close, but not quite there yet. We were hoping that it would be rolled out by January, and we just aren't quite there yet.
I think the other thing just to take into account is that DCF is a really large agency and that rolling this out also requires training all of the DCF specialists too, which is a huge undertaking. And so I think that's been the other piece of it is that, you know, to go statewide, there is a lot of training and education, and DCF really didn't want to train staff to do one thing and then, you know, a few months later be like, never mind, we're using this IRIS system rather than this system. And so that we felt like would be confusing. And so we thought we would have a better chance of just overall success if we had all the layers in place, if we had had trained medical providers, if we have a, you know, online referral system, that we didn't have to train people to do one thing and then 3 months later say, never mind, do this other system. So we just thought we'd have a better chance of like having a successful rollout if all of that infrastructure was in place before saying go.
Okay, gotcha. Representative Johnson.
Thank you, Madam Chair. First, this is a critical goal for us. We have to continue this program. I've been there with the kids, asked to examine them. I'm not a doctor, and I'm so thankful for what you're doing. It's the next step. Training, like you mentioned, for DCS, I want to bring up, how are we looking at law enforcement? Because I know we have support now from the criminal justice or from the law enforcement field. Where are we at in the academies and that type of concept?
I know your resource center, so Kansas City and Wichita, we do trainings with our local law enforcement academy. I do one with KBI, new recruits every year. So they're happening. They're not happening, I think, consistently across the state, and that's something that certainly we can build on here. As we've developed this system, it has sort of been the expectation that the vast majority, maybe even all, referrals would be coming from DCF. DCF is not always involved before law enforcement, but frequently is involved before law enforcement as the hotline comes in and then a police report comes in after. And so I think it's an area that we need to look at moving forward, because I agree, law enforcement has not had training on this program yet.
Would you consider taking them into the standard training that you're doing with doctors?
I think, so we have worked with DCF on training in the past few years. We've done multiple different trainings with DCF. I think it's helpful to have separate trainings. I think we could certainly do one for law enforcement and DCF together or separate, but I think it's helpful to have a separate one for medical providers, just because we're getting into so much like pathophysiology and ordering labs and radiology results. It's not always, I mean, certainly you'd be welcome. I just don't know if it would be the most helpful, if that makes sense. I feel like we do similar but slightly different.
So do we need more money for that?
Well, I would say not necessarily, because I think we have the infrastructure there. We have the ability to do more trainings. I think it would more just be the right communication.
I think if we wanted training to be part of this program specifically and explicitly, I do think there would have to be more funding for it. I think, again, I think that we have the infrastructure to provide training in some places, but I tell you, if you call me from like in Goodland, I can't go to Goodland and do training, you know, like I just can't do that. And so I think like systemically, if we want that to be there, it probably does have to have specifically funding in this program.
How much?
I don't know. We can work on that.
I would like to see that. I'm a strong proponent for that. If we need to make it a mandatory part of our basic training academy, because not every academy teaches the same. You've got the ones in Johnson County, out at Hutch, a couple other agencies. I think that's something we need to look, because you'd be surprised how many cases law enforcement will see for officers in the field. That's from personal experience. I'm the first one there. I'm a patrolman. Oh my God, this is a little kid. What am I going to do? And we can help you. Again, I commend you for what you're doing. Thank you, Madam Chair.
Representative Carr.
Thank you, Madam Chair. You probably went over this about 4 times. I think I was with you on about the 3rd time and then got lost on number 4. So with respect to the child that's 5 years and younger, anytime there's a call, that would then constitute a referral. Am I correct?
So when DCF gets a call, they have an internal system where a call either gets screened out because, you know, somebody called and said, I saw this little kid at Walmart getting hit, but you don't know who he is or how to find him or whatever it is. Or they're saying, you know, this kid was playing in his grass barefoot and somebody didn't like it, so they called in a report, but it's not actually abuse. Those things get screened out. But if it is screened in as a concern for abuse or neglect, and as it's assigned for an investigation, DCF also has the option to assign things as assessments, and so those are sort of other concerns. But if there is an abuse concern that gets assigned as an investigation, all of those get a referral for 5 and under.
Okay, so with respect to that, when you say it's assigned as like a possibility and the child's under, how do we make that assessment over a telephone that a child that's under 5 years of age, that confuses me. If it's worth investigating, then should that not constitute someone going out and physically, visually, at least visually looking at that child, and then from what I understand, if it's worth the DCF agent to go out and take a look physically, then it should be qualify as a referral. Is that?
You have it exactly. So if it's assigned for investigation, Adrian's law that went into place a couple years ago requires that DCF go look at them and lay eyes on them, and this will require them that they have a referral. So both, yes.
Okay, and that's only for children 5 and under.
So I believe DCF has to lay eyes on everyone assigned, regardless of their age. The referral is for everyone 5 and under, or they can send them to us for kids older, but it's mandated for 5 and under.
Okay, thank you very much. Thank you, Madam Chair.
Representative Ousley.
Thank you, Madam Chair, and good work, doctors. That's the map is impressive. Where all you've gotten in such a short time. The law enforcement officer comment a moment ago or question got me to looking ahead at written only testimony. Have you had a chance to look over Ed Klump's and are you okay with his suggested amendment? Okay, I just wanted to verify that while we had folks in the room. Thank you much.
Are there further questions? Was that? Oh, I'm sorry. Representative Howell.
It's the short one. Yeah. It's okay. Thank you, Chair. I just wanted to, just in gaining a better understanding, I'll just use a personal example from my own family decades ago now. I had a sibling that was very young, but had alopecia areata. And there was a report of abuse filed from someone probably in the neighborhood that thought we were yanking her hair out. And so they filed a report with DCF, and DCF came to her home. And so obviously my sibling was running around without hair on their head. And but in that case, my mom was able to show, give them the dermatologist, so some documentation of visits to the doctor, things like that. And they said, thank you very much, took the evidence, I assume probably called the dermatologist, confirmed, I assume. So if you had a referral of that kind of nature, you would do something similar, I assume, and then say, okay, this seems like a legit medical thing, and this is now done.
Yes, that is a great example. That would be, and DCF has honestly been excellent when they have, additional medical input from other places. So if the child has a specialist, or I had medical records from a neurologist that was sent. So things like that is an easy, nothing to do. Checkbox. Yes.
On the other hand, can you give an example of where a child, if a DCF employee was there and there doesn't appear to be anything wrong, but then they go through the thorough exam and something else can be found with x-rays or?
In our first 2 weeks of the pilot program that we started, so it started in October, November. In our first 2 weeks, I got 2 different examples. One of them was a kid who he was about a year old. He started at a new daycare, and the daycare reported, I don't know the daycare reported, let me back that up, it's confidential. I don't know, someone reported, probably the daycare, that he had bruising on his body. And so DCF got this, they went out and looked at this kid and said, yeah, it kind of looks like bruising. And they sent it in, and I said, do you have photos? And they said, sure, here they are. And they sent them to me, and I said, that doesn't look good, bring him in. So he came in, and mom came in, and she said, this has always been there, this is what he looks like. And I was like, really? This is kind of odd. So we talk a little bit more about it, and she's like, he saw a specialist for this. And mom was able to give me some more information. She was a terrible historian. If she'd have told DCF this, it probably wouldn't have made it this far. But we got there, and eventually he did have a dermatologic condition. It had been very well documented. It matched exactly, and I was able to give that information back to DCF and say, this is okay. This is what he looks like. A few days later, we got a report from DCF where I don't know who made this report. It was a great catch, whoever it was. It was a baby that was 2 months old who had actually been seen in, I'm going to throw us under the bus, a Children's Mercy urgent care for not using his arm correctly. The parents brought him in, said he wasn't moving his arm the right way. The urgent care doctor who saw him said he looked great, no bruising, nothing on his body. They didn't see anything, and sent him home. Subsequently, DCF got this report, And we said, well, that's really weird. Babies don't stop moving their arms. We brought him in and he had multiple broken bones in his arm and nothing on the outside of his body. And so both of those, they were sort of like my validation that this was what we needed to be doing, because they came in so quickly at the beginning of this pilot program. And that was just Johnson and Wyandotte County. And in 2 weeks, we had 2 great examples of why we do this on both ends of the spectrum.
Thank you. That was a great response. Are there other questions? This is your chance. We have the experts here. And I'll add, thank you for what you all do. I know you're both physicians at Children's Mercy with another full-time gig, and so I really appreciate the work that you do. I was under the impression that you would be contracting with DCF for your payment.
So the way it sort of works is, so KDHE has the fiscal note. They have contracted with KAAP, and we then subcontract with KAAP. So Children's Mercy does have a contract that reimburses for our time in these, for the time that we do training and our mentoring of these, of our care providers, and the time that we are doing things for the project. So yes, Children's Mercy does have a contract and does get reimbursed for our time. The Resource Center in Wichita also has one, so that those docs are also reimbursed for their time on this project. Well, the hospital is reimbursed.
Okay, all right, thank you. Okay, oh, Representative Carr.
Thank you, Madam Chair. I do have one question because I'm certainly not an expert. We have this age set at 5 years. In your professional opinion, is that a good age? Or should it be older?
I think so. Clearly, older kids are abused and neglected, and we know that. The thought process with the 5 years of age is really looking at national data. And so your highest risk for dying from abuse or neglect is if you're 5 and under. The other thing is that kids 5 and under are the most likely to need labs, x-rays, additional imaging. They're less verbal. They don't have as many eyes on them because they're not at schools. They're not, out in the community as much. And so I think it's the most vulnerable population and the population most likely to benefit from this really thorough medical evaluation. Now, certainly we see kids older than that too, but I think if we're targeting age of a child to be involved in this program, we have it right.
Thank you. Thank you, Madam Chair.
Anything else? Okay, thank you very much. Thanks for being here.
Thank you. Thank you very much.
Okay, committee, so the rest of the proponent testimony for this bill is written only, and it's in your folder. So we have support from Safety and Thriving Families and Performance Improvement, Deanne Dinkle. Ed Klump, that's been referred to from the law enforcement side. Rachel Marsh has testimony from Children's Alliance of Kansas. Okay, I'm not going to try her name. From KDHE. I'm sorry. Can anybody tell me how to say your name? Dalrymple? Okay, Allison. I'll call you Allison if that's okay. This is kind of a complicated bill. So if you take a look at that written only, and if you have any questions, they are actually in the room. I actually have a question for Tanya with DCF. And we have DCF written only in here. Yeah. Is that listed here? It's okay. It's in the folder, but it's not listed on your proponents. Tanya, when I was explaining this last year, I can't remember what the numbers were, but it was the number of calls that come in and then the number of calls that actually get, I don't know what the right word is, investigated maybe isn't, but it gave the impression to some people that DCF was like way behind in responding to these calls. And I just wanted to give you an opportunity to explain maybe how some calls are easily moved into the category of not needing to be investigated.
Sure. Thank you for the question. I'm Tanya Keys, Deputy Secretary with the Department for Children and Families. When a call comes into our agency from anywhere, it goes into it's received by our Protection Report Center. There are statutorily as well as within our policy, there might be reasons why we receive a call from someone's worried, but their worry may not either be within our authority to respond to or doesn't rise to the level of us assigning it. So we have terms of we receive a report and we make a decision on whether or not to assign. Some reports that we receive are not assigned. Others are assigned. I'll give you an example of a report. DCF may receive a report for Wichita, Kansas, which is in Sedgwick County, that might be regarding a child who's alleged to be a victim of some type of sexual act or sexual abuse. The perpetrator is alleged or described not to be related. Somehow maybe something happened at school or something else. We have a memorandum of agreement with the city of Wichita, their exploited and missing children's unit, where if the alleged perpetrator is not a caregiver, not related, that DCF does not act in that investigation. In other words, it is deferred in Wichita to the exploited and missing children's unit. We have agreement for that. If there might be a child protection issue, perhaps a parent or caregiver wasn't protecting, we might be involved. But there are a number of reports that, depending on the relationship of the alleged perpetrator, that law enforcement might take the lead and would ask DCF not to proceed because there's not a protection issue. We might need to proceed with an investigation for criminal, but child advocacy centers and law enforcement sometimes proceed with an investigation and they let DCF know. There's no role for DCF, so DCF will not complete the investigation. That's one example of when we receive a report, someone's worried, but with that initial information, we're able to determine DCF doesn't have the authority to proceed. Another example of a report we receive, so for example, we might receive 72,000 reports in a year. About 55% of those are assigned. We also receive a lot of duplicate reports. So if we receive a report from law enforcement and a school and a nurse, that's 3 reports we receive. We're only going to assign 1 because they're the same incident, the same alleged perpetrator, and for the purposes of us responding to the family, we just need 1 report. We don't need all 3. So it makes it look like we only went out on a third, but we went out on 1 to represent the totality of the worry that was sent to our agency. Does that help?
That helps a great deal. Thank you. And what is the time frame that you have expectations that for DCF to respond?
Our response times are, depending on the nature of the concern, same day or within 72 hours, excluding holidays and weekends.
Okay. All right. Thank you. Does anyone else have a question to follow up that? Representative Johnson.
Thank you, Madam Chair. Reference to Chief Klump, his comments, for the new people on the committee, he represents the 3 major law enforcement agencies as their liaison and meets regularly with them before we come into session. And then, so when we get information from Chief, it's good. It means he's representing what the interests are, all 3 of those organizations. I'm still a member of the Sheriff Association, but he is an excellent person for sharing that, what is the law enforcement community's wishes without us having to bring in multiple policemen, chiefs, sheriffs, et cetera. Thank you, Chair.
Okay, thank you. And thank you. Thanks, Tanya, for letting me put you on the spot there. Okay. I only have proponent. So I'll close the proponents. I I don't show any neutral conferees. I don't show any opponents. So at this time, I will close the hearing on House Bill 2034. And committee, we are not going to try to work any bills today. I will, let's see, I think you've got some minutes in your inbox. Did you email those? No, just I have. Okay. You will get some minutes in your inbox. I need to review them first. And as of starting next week, we are going to go paperless. I'm sorry. I'm sorry. I'm sorry. Well, what? No. So she will send the testimony out, and if you need, we're taking care of kids. We need to take care of our trees too. If you will receive it via email, and if you need a printed copy, you can have your staff print it. But we're going to give that method a try. Representative Humphreys.
Thank you, Madam Chair. I just would like to make sure we somewhere put in our minutes or something that we do want the report from the pilot program and also the breakdown of the request of the funding. Those two, those two things. And I would like to point out that trees are a renewable resource and we like renewables. Thank you.
Okay, any other announcements for the good of the committee? Okay, we're adjourned. See you Monday.